Welcome to Rheumatology Watch. I'm Paul Bird, Associate Professor at the University of New South Wales. Today's presentation will focus on Apremilast in psoriatic arthritis. This is in line with the recent listing of Apremilast for psoriasis in Australia, and it's an opportune time to review some of the data for the medication used in psoriatic arthritis. The suite of trials is called the PALACE studies. To remind you of the mechanism of action of Apremilast, which the trade name is Otezla, this drug works by inhibition of PDE4 within the cell, so it's an intracellular molecule. You can see from the diagram there, it inhibits cyclic AMP, conversion to AMP, and that has some downstream effects, particularly on NF-kappa beta, which has a large number of pro-inflammatory mediators associated with it. And so they're downregulated by this medication, and anti-inflammatory mediators such as IL-10 are upregulated. The phase 3 program overview is 4 independent phase 3 studies. This is undertaken in patients with active psoriatic arthritis several years ago now. But as I said, an opportune time to review this data with the listing of Apremilast for psoriasis. PALACE 1, 2, 3, 4. You can see the information regarding those trials there on the slide. All have a long-term extension. Across the slide there, you can see a large number of randomized patients, and you can see all have a slightly different flavor. PALACE 1 was active PSA, DMARD or biologic experienced. Number 2 was active PSA, DMARD and or biologic experienced. PALACE 3, active PSA, DMARD and or biologic experienced, but they had to have a psoriasis plaque to come into the trial. And so PALACE 3 has a number of outcome measures that include skin, and PALACE 4 was active PSA, DMARD and biologic naive. Large numbers of patients, as you see in all the trials. This is a summary of the study designs for all of the studies. So this is PALACE 1 to 4. Patients were screened, they came into the trial and went either to a placebo or to Apremilast 30 or Apremilast 20. The primary endpoint is generally the ACR 20 at week 16. And at week 24, patients would be re-randomized to Apremilast 30 or Apremilast 20, followed over a year during a blinded active treatment phase, and then to a long-term open label phase over 5 years. Let's look at the setup for PALACE 1. So these are patients receiving Apremilast, and I'll put this in to show you the number of patients at the bottom of the slide that actually complete the trial. This is interesting because this drug does have a very good safety profile and low adverse event profile. So we can see at 52 weeks, on the 20 arm and on the 30 arm, we've got over 70% of patients completing the trial. And that's quite an impressive number of patients getting through that 52-week period and not withdrawing from medication. Let's look at PALACE 1 to 3. This is pooled data, which gives you an idea of some of the patient demographics and clinical characteristics by the different treatment groups. Placebo, Apremilast 30 and Apremilast 20 there at the top of the slide. Look at the first line there, the age, gives you an idea that these are the usual age of patients that we'd see. There's a reasonable gender distribution, female 51%, 55 and 53. Note the body mass index there, so that's important. This medication has been tested in people who do have an elevated body mass index. Many had prolonged duration of PSA on the fourth line there. And if you look down through the activity scores, they've got fairly active disease, and a large number of them have baseline NSAID use on the bottom line there. Small number having baseline corticosteroid use. Let's now look at the responses. This is in PALACE 1 to 3. And it gives you an idea of the responses for the ACR 20, 50 and 70, firstly over the initial 16 weeks, but then right out over 260 weeks. And let's look at the different ones. ACR 20 is in the darker green, the middle green is ACR 50, and the ACR 70 is the light green at the bottom. Initially, I'll take your attention to week 16 there. You can see the separation very early at the primary endpoint. So the drug's achieving primary endpoint there. But then watching over time, what you see from those graphs is continuing improvement right out over the 260 weeks. So early improvement, and a reasonable proportion of patients achieving ACR 50 and 70 there, which is really what we're after, but also that effect maintained over time and increasing over time. Let's look at the patients in PALIS 4 who received Apremilast 30 twice a day over 208 weeks. So this is one of the other studies in the suite. Now again, looking at this ACR 20, 50, and 70, different coded blues there, you can see them on the slide. Look again at week 16, that separation occurs early. So we see an early separation, the ACR 20, 50, and 70. So achieving those early. And then we're seeing as we go out over time, there's that continuing improvement over time. So an ACR 20 of about 68%, 50 of 43%, and then 70, 23%. So early response at week 16, but continuing response over time. What does the impact of baseline weight have on ACR 20 responses? This is the question we often ask ourselves as clinicians. Is the patient, and we know that many patients with psoriasis and psoriatic arthritis have elevated BMI. The data here shows you baseline weight and baseline BMI in the left-hand column. You can see the numbers running across in the placebo group, the 20 and the 30 group. And what we're seeing from this, and what the takeaway message is, that we see similar ACR 20 response rates across all weight and BMI ranges at week 16. And those treatment effects were maintained out to week 24. So regardless of the baseline BMI or weight, there certainly is a good response. Another important facet in patients with psoriatic arthritis is improvement in enthesitis. This slide shows the improvement in enthesitis from PALIS 1 to 3, the pooled data, for the 20 and 30 milligram dose using the Macy's score. You can see this goes over 156 weeks. The mean change in baseline is presented on the axis on the left. So I draw your attention to week 16. You can see an early improvement there. But what's important with this one, enthesitis, there certainly is a continuing improvement over time. So at week 24, we're seeing 29 and 33% in the respective dosages. But that improves. So when we get out to week 156, we're seeing 57% achieving that change in baseline and 65% in the 30, that change from baseline in the enthesitis score. So works for enthesitis, early effect and ongoing effect. Dactylitis is another important feature, one that can be very refractive to synthetic DMARD therapy and often requires biologics. This is the mean percentage change, again in the 20 and 30 groups from the PALIS 1 to 3 pool. Again, you're seeing that quite significant improvement very early there, at 24 weeks, quite a significant change from baseline in dactylitis early, but then continuing out over time in impressive figures there out at 156 weeks. So dactylitis improves with Apremilast. Let's turn to adverse events. I think one of the things that we do see with this medication is some side effects. I'll draw your attention to the bottom of the slide here. Diarrhea, nausea, headache, upper respiratory tract infection. These are generally manageable by either reduction in dose or tailoring of the dose to the patient by reducing the 30 down to 20 or reducing the dose or having a break from dose for a short period. Importantly, when we go to the top of the slide, we see that serious infections are very low and adverse events leading to withdrawal of drug are extremely low. So that's a very important and beneficial effect of this drug, that AEs are low and most of the AEs are non-serious AEs. So it's a very attractive option for rheumatologists and indeed for patients. So completing that Apremilast overview, we can see that this intracellular molecule is not only effective across many of the facets of outcome measures that we use in patients with psoriatic arthritis and psoriasis, including enthesitis, dactylitis, joint counts, also improves psoriasis, and has a very favorable adverse event profile, making it an attractive option early on in patients with psoriatic arthritis.
Well, that concludes the presentation. Thank you for watching.